So this is hopefully to be a boot camp tour de force of what you need to know for HIV/AIDS, and we can always go into other topics as you like. So I don't have any conflict of interest. I was 8 years at the Department of Health working at their USF Clinical Trials Center, also as their Director of Disease Control, working with the wonderful Dr. Sambunwit, and that was great. And now I just transitioned to the VA. So as we know, I'm now VA side, but I'm still very involved with national and state efforts for HIV control. So December 1st is always World AIDS Day. And why are we really worried about HIV, right? HIV's been around a while. Why are we perseverating on this? Well, it's because we need to end it, and we need to know how social determinants of health impacts HIV infection and how this has actually been amplified by COVID-19. And why is that important? Well, HIV infection is impacted by monkeypox virus, by COVID-19, by everything else in the social milieu. I'd like to give you an update on HIV science, prevention, treatments, and vaccines. I'd like to also talk with you how you can identify and refer new HIV cases, because when you're in clinic, sometimes it's a very controlled environment. You see folks are already suppressed on their ART, you have a good conversation, you make sure they're up to date, and then you say goodbye, and you see them in 6 months. Well, in the real world, sometimes you got to be that person who identifies HIV. You got to be that person who refers them to care. So that's, I think, the challenge and the responsibility of ID docs is always keeping that in your differential and knowing your networks in terms of where to refer people and how best to refer that person for care. So how do you overcome barriers and stigma, especially in the Southeast? We have a lot of stigma surrounding HIV. What is U equals U? We're going to talk about that. Updates on PrEP and NPEP, and then some updated provider resources. So this is the epidemiology, and I wanted to bring this home because this is really tied to the social determinants of health. Infectious disease is a specialty in its own right. It's very determined with the environment, with people's interaction with other people. That's why I love the profession. That's why I went into this specialty, is because it's very rewarding, but also you can make a lot of wonderful changes and leverages in terms of getting people, back on track and preventing and curing disease, which is another wonderful thing about infectious disease. Can't cure HIV yet, but we're working on it. So there are about 37 diagnoses in 2018. Now, 2022, we're up to about that number. Unfortunately, Florida is one of the top, both in new diagnoses and total prevalence. You can see there are demographic disparities in HIV still, unfortunately, persisting. That's changing a bit, but we're trying to get those levels obviously down for all groups. Why is that important? Well, that affects messaging, that affects how we reach out to different communities. The South is 51% prevalence. Why is that? There are many concrete, real reasons for that. But I think suffice to say, we are practicing in that region. So we have to be very aware of testing for HIV, prevention for HIV. If somebody comes to you with an exposure, or even an STI, you need to have that conversation about HIV prevention through PrEP. So as infectious disease doctors, we're really on the cutting edge and really kind of on the ground in terms of that surveillance. And so how are people getting HIV? So basically, it's currently a male-to-male sexual contact. However, we see it in injection drug use, especially in the Northeast and in parts of the Midwest. We also see heterosexual contact. Really, anyone human is at risk for HIV. It's even occupational exposure. So it really is a general population-based virus, as is monkeypox is quickly becoming that as well. So it's very important to kind of keep that in mind as well. And just to say, we have all types of folks in the health department space and the VA space, all types of groups, all types of socioeconomic groups. So really, anyone can be affected. Diagnosis among MSM, so men have sex with men by race, ethnicity. Now, why is this important? This is important because our African-American MSM are highest risk. And it's important to reach out as a public health person for messaging and also for bilingual materials for our Latino community as well. And we have made success. So we've had some successes. We've decreased those rates. We still have a way to go, but this is just something for the socioeconomic determinants of health. So something else in your practice as infectious disease physicians, there's a lot of politics and flurries around it, but transgendered individuals, right, are really important to consider, to include in your clinic, to obviously make them feel welcome, but also to know that this is a risk group as well. So having those conversations the same as you would with any other patient that you see, but also not being afraid to ask a sexual health history, and we can always talk about that more in detail, but becoming comfortable as a physician with those conversations and having that safe space to open up for someone to open up and tell you maybe their risk factors and if they'd be interested in PrEP or HIV care or HIV testing. PWID is people who inject drugs. So there is, as you know, from the COVID epidemic, there has been an opioid, unfortunately, resurgence of people using. That is because people couldn't access mental health care, a lot of isolation. So that's also, unfortunately, a risk factor for HIV in our injection use drug population. And you'll probably hear about needle syringe exchange programs that various groups are working on as well to address that. Now, Florida is a wonderful place to live, but it is terrible for HIV, and there are many reasons for that. We unfortunately have been towards the top for multiple years now. It's actually one of the main reasons why I'm down here is to work on the HIV public health outreach in Florida. And you can see, like many of our diseases, unfortunately, we have a lot of kind of epicenters and then spread to other areas, but still very high prevalence in Florida specifically and along the southeast. So just for those, you're all so wonderfully young, so I wanted to just give you a little bit of history. Did you know what this is actually? Oh goodness.
Isn't that like the like blankets they put out? They would do like squares and stuff like that,
Yeah.
memorials to people. I was alive for this.
Yes. So this is in the 80s. So this is. Does anybody else recognize? Thank you. That's very good. Anybody else? Okay. So yes. So to take it really to add the gravitas to this, each quilt, each square. So this says Tom down here. Each square is an individual who died from HIV and AIDS actually at that time. And why is that important? Well, we didn't have medicines back then. We didn't have the science to even produce the medicines really back then. We didn't have the genomics. And why is this important? Because the HIV epidemic really started well, we can talk about it, but basically we think HIV was around probably in the 40s, 50s, really started accelerating around the 80s, 90s. And at the time, we didn't have medications. At the time, there was such a stigma, similar to monkeypox today. It was considered, no, it's, men SM, and, it's people who, shouldn't be doing things they shouldn't do, and that's the stigma of it, right? But that's not true. People got it through transfusions. People got it through just having normal relationships about their lives, right? So what happened because of stigmatization and there's no treatment, a lot of people didn't get tested. A lot of people, unfortunately, passed away. And so this really brought attention to the national sphere in a very, very powerful moving. And I've actually seen these quilts hanging. They rotate them in and out of their collection at the Kennedy Center there. And it's very, very powerful. These are obviously sons and brothers and, very, very well revered in their community. And anyway, the reason I'm bringing that up is because I think it's important to understand what an impact HIV and AIDS have had on our country, how it continues to wreak havoc, but also with our new epidemics, be it COVID or monkeypox, we have to be so vigilant because it's unfortunately sometimes the same story repeating itself in terms of, not having testing, not having vaccines, not having treatment. So just in terms of knowing what's going on, not to belabor the point, but I wanted to show you that's why this is so powerful. And these, they're called AIDS quilts or HIV quilts, has actually been in other cities as well. So other cities started doing this as well. And these are in archives and museums. So just the gravitas of HIV is very powerful. We've come a long way, but we have a long way to go. Okay, so social determinants of health. Why does that bother us? Well, if someone is diagnosed with HIV, unfortunately, like many things, COVID, diabetes, heart problems, right? Where someone is in their socioeconomic level, unfortunately, affects how they do, right? So basically, you're seeing here poverty lines, and then you're also seeing the diagnosis. So as unfortunately, the more somebody is below the federal poverty level in this red, the more likely they are to acquire HIV. That's true for tuberculosis in some senses, right? People don't have access to care, people are higher risk, or around people who are higher risk who may not be engaged with the healthcare system. And as good as our healthcare system is in the United States, it has so many weaknesses because we don't have that really cohesive network that we can get people to care. We have the wonderful public health departments, but there's a lot of people who may not be able to access that, who are not into care. So that's what I wanted to bring out, is that even, so you have categories, which are somewhat artificial, but you have categories, but then you also have poverty and then access to resources, which also affect care. Now, HIV acquisition. This comes up a lot in occupational exposure, in patient conversations. Blood transfusion. Remember, we didn't screen the blood supply until what year? Do you remember?
I want to say it was pretty mid to late 90s.
Yeah, 85 around there. Yeah, 85. Late 90s it probably, went through, but right, we were unfortunately spreading HIV through blood transfusion, hepatitis C through blood transfusions, right? That's why we screen the baby boomer population. Hepatitis B, so they did a study that actually did archive blood supplies of people who acquired HIV, and they noticed they had been actually exposed to hepatitis B before. So there's a lot of, exactly, very good. There's a lot of things that we've done. Other things that, remember that people rotated with me, the air gun vaccines in the military. People would line up. It's an air gun vaccine. It was oh my gosh, it was run by air. It's called it's like a pneumatic vaccine. And basically when the blood would squirt back, the person on the front line, if they had Hep C, they would potentially give Hep C to everybody down the line. It's horrible. It was done regularly for a while. We recently stopped, thankfully. But the reason I mention that is because our veteran population has a very high risk of hepatitis C, and same anybody going through that. And also, unfortunately, we've seen that in vaccine campaigns, specifically in Egypt. We know that actually happened as well. The needles were reused, not by the United States, but the needles were used. So that was a problem as well. So that's something to keep in mind when you ask about your medical history. Have you been in the Army? Have you been traveling? Did you grow up abroad? Those are really important questions to ask. All right, so needle sharing, injection, drug use. Remember, it's a very efficient, unfortunately, way of spreading virus, right? So whether it be Hep C, HIV, name it. Percutaneous needle stick, absolutely. So these are rate per 10,000 exposures. Now, conversations come up with patients about, not to get too graphic here, but just be aware there are many ways of spreading HIV. So that's always good to ask a good history. But also in terms of your own work and your rotations, just universal questions are fine, but I always give our patients a pep talk about no risk to household contacts, and then also U equals U, undetectable is untransmittable. So it's important to know the exposures, but it's also important to destigmatize HIV, because once it's controlled, it should be absolutely fine, and it's negligible exposure. Okay, so moving on, sorry. Okay, so this is really exciting. So the CDC has really kind of pivoted in terms of its outreach. It's become a lot more, I think, patient-centric. I think it's become a lot more aware of the real risk factors for transmitted HIV. And so there's a really nice risk reduction tool with HIV that you can take a look as well, and you can refer your patients as well. I think it's really nice. It's very good information. I think it's packaged very well. So I'm going to skip over this. This is HIV diagnosis by top states. So unfortunately, this was 2017. We've actually come up quite again. But Florida and Georgia, in terms of actual states, have been high. We also have, a large general population. So, it's in terms of percentage, but also per population, we're also very high. So this is just in 2017. With COVID, the reporting wasn't as up to date, but this is the latest one that I have. You can see that we're number 18 in the country right now. This is the prevalence of diagnosed HIV infection. So we have a lot going on. The rate, that's why I put this on here, is because population obviously can change, but we're here in terms of the rate here as well. And a lot of our cities are affected. Okay, so this is what I wanted to show you. The map of HIV prevalence is similar to the prevalence of diabetes, cardiovascular disease, and COVID-19. COVID-19 has really complicated HIV care. I know this is an HIV talk, but just know it's hard getting people into care. It's getting better now, but just so you know, telehealth has really been able to get people living with HIV into care. So I won't go too much into that, but just to know. Okay, basic science and treatment update. So treatment is prevention. So basically what to remember looking at these is before someone was diagnosed with HIV, we would wait, we would kind of see how they did. At that time, the antiretrovirals were very toxic, so we had to wait sometimes. And we had to make sure someone would really wanted to take it, not go on and off of it. Now, thankfully, we're really test and treating. So we test them, then we treat them right away. And there was a wonderful landmark study, the HIV prevention treatment trial, HPTTN trial. One of those were showing that if you actually treat somebody, you can prevent the infection rate. So Let's jump in here. So those of us here with me have seen this a little bit, but we're gonna, this is from the NIAID, NIH. First, the virus will fuse to the host cell, okay? Like many viruses, right? COVID will fuse to the host cell. So a lot of this is similar, but what's important, this is your CD4 receptor. So the excellent talk by Dr. Canella, you saw all the T cells and B cells and everything. So this is your friendly T cell. And with the T cells, there's CD4, there's CD10, there's a lot of receptors. This HIV virus is very smart. It will dock to the CD4 receptor. And the P120 on the HIV virion will dock on there as well. And it's literally, unfortunately, like a spacecraft. I mean, it basically docks, the proteins grab on. And what happens is the virion then is basically fusing to the membrane. So you have the fusion. I'm just going to go back. And then you can have, what happens is the RNA, right? It's a reverse transcriptase inhibitor. So the RNA goes into your DNA, actually human DNA, unfortunately, integrates into the DNA. So it fuses, and then it basically, these are the, I'm not sure if you can see my mouse. Yeah, you can, great. You can see the working end of the HIV virus. You can actually, the reverse transcriptase. So basically the RNA is becoming into the DNA, it's integrating, right, into the human DNA. Why is this so important? Well, our early HIV drugs would have mimic analogs for this reverse transcriptase. And why is that important? Well, because it stopped the replication in its tracks, right? It's like you're putting the wrong Lego in a train, right? And so it stopped the virus from replicating. And so most of our early HIV drugs here, that's how they started. And AZT, remember, was a cancer drug, right? It was an anti-cancer drug that was kind of taken off the shelf, and it had some activity. So that's why that's important. So that's why that class became very important of drugs. Now, integrase inhibitor, it stops integrase. Now, this was a later development, but this is so important because this is such an efficient step in terms of if you block it, it becomes very efficient in stopping replication. It also stops integrase from working. So this is very important as well. So your medications like elvitegravir, bictegravir, those are all integrase inhibitors, and they stop the viral DNA. This is the host DNA, all right? And so once it goes to the host DNA, it starts replicating, and then it makes new viral DNA, okay? And why is that important? Well, because those medicines called the protease inhibitors, they will inhibit this protein budding, all right? So that's important too. They have their own side effect profile, but that's where they work on the process, right? So it's a whole process, and all the drugs work on the specific process, and then there's a maturation of the virus. And this just shows you maturation inhibitors. We don't usually use those because it's obviously the late stage, right? And it's already integrating in the genome. So we try to really go upstream, if you will, and the non-nukes and the nukes are reverse transcriptase inhibitors, integrase inhibitors, protease inhibitors. So that's, any questions on that before I move on? It's like a nice way of thinking about the process. This is it's a Fauci slide. I love this slide. It is so old, but I love it because this is what we think of HIV. And unfortunately, the natural history of HIV. So I'm going to start with primary infection and viral load. So in your practice, you will probably see a new HIV diagnosis. Viral loads, we've seen, gosh, anywhere up to tens of thousands, sometimes even 800 or so copies per milliliter, though, right? And so primary infection, there's a very high viral load. That's when people have those fevers and chills, sometimes, not always, maybe have a rash. It's hard if they also have COVID, which we've seen also. And then they come down, right? Somewhat, depends on the person. And then there's kind of this control of the body, right? Trying to fight it off. But unfortunately, it's not sustainable. And this virus goes through, this is your CD4 count. Your CD4 count will actually go through a latency where you're not be able to detect it, and then it'll drop, okay? Same with the virus. This is, of course, no virus. This is the high virus here, and then it will plateau as well, and then it will just take off, unfortunately, without any treatment. Why is this important? Well, a lot of our diagnoses happen in the clinical latency period where people are feeling fine. Remember, it's a lentivirus, so it's moving slowly. And so that's why as clinicians, if something doesn't add up, if they have a condition and you're wondering why, then I would definitely suggest HIV testing. Why is this also important? We're seeing now diagnoses for whatever reason of the CD4 count, which is normally around 1,000, moving down, being at a lower level at diagnosis. So we've seen new diagnoses now at lower and lower levels. Some of that has been somebody infected for a long time, but some of it, for whatever reason, can be actually just a lower set point. It's called a nadir, the lowest that they've been at. If you see a patient with a nadir or a low point, less than 20, it's going to be harder, right, for that bone marrow and their body to produce those T cells coming back. So you're probably going to be with opportunistic infection prophylaxis for a longer time period. But again, if you see somebody early and you test them, then they're probably going to rebound a lot more quickly, and they'll have a better health outcome. So it's another reason why we like to test early. We get people on treatment, and then their immune system will rebound. Have you heard of the START trial? That was a really important trial. Okay, so the START trial was to address that very question, right? Do you wait for people to drop their CD4 counts, or do you start them right away? And the answer clearly was you start them right away. There used to be these very fancy guidelines. WHO would have them, US would have them, Europe would have them. Oh, if you're above 600 or above 400 or above 200 or below those numbers, basically, but that now has got away, thankfully. So you don't have to artificially look at the CD4 count. You just start them on therapy, which makes a lot of sense. So testing for HIV in Florida. In the health department, they do offer free HIV. Used to be free. They've sometimes added some fees for STI testing, but in a perfect world, it is free. They have HIV testing outreach. There's actually home kits that the Department of Health used to mail out as well, and it kind of waxes and wanes depending on their availability, but something to ask. Also, your patients can get these in CVS. They can also go to an HIV testing site in the Florida Department of Health area. And the VA, of course, we can always I wish I could rapid test. We're working on that, but we can also HIV test them as well. There is stat testing for occupational exposure, and also for Endpap for post-exposure prophylaxis for patients as well, of course, in all settings. So hopefully that helps. Rapid testing is great. It can be, as you know, through finger stick. It can be oral. You can also do rapid testing for hepatitis C. I worked actually for, 2 years working on rapid HIV and Hep C co-testing, which was really, really wonderful. So that's also possible. All right. So what to look for at the HIV infection? What you're looking for when you're looking at somebody being newly diagnosed. Changing gears a little bit. So you're looking for this P24 antigen and the GP120. Our tests have gotten better and better over time. It used to be where you would really need to get that viral load, make sure they were not infected, and an antibody. The antibody now is very good. I would still get a viral load if you're really worried. But you can see as many viruses, the plasma will increase first, and then the antigen will follow. So this is another important slide just to kind of keep in your memory. This is the GP120, and this is the P24 docking. This is a nice marker. We don't do Western blots anymore. Do y'all hear about Western blots? We used to do these kind of nice Western blots, and it was the standard of care for a while. Thankfully, the science has evolved, so we have a lot more rapid diagnoses. But in the day, it was very important to establish diagnosis. Luckily, we're moving away from that, and the fourth generation is really, really doing well in terms of testing. So testing and treat. So in your practice, and I would also encourage you in your inpatient rotations, coordinate with your attending, depending on how you want to get care. Really test and treat is really important. Even we call it a warm handoff or a red carpet, basically making sure that individual gets care for their next ID appointment. When I worked with Rapid and really in the field, we would actually have a mobile phone, the flip phones, and we would call, our folks would call the clinics and get them in directly. So that way they have an appointment already set up. So that's ideal. So have, social work team or something, or call, reach out and make those appointments. And we actually have disease intervention specialists who will come in to the hospital setting. It's gone off and on with COVID, but they will also make those connections. So data, it definitely shows better long-term virological suppression and adherence is better immune reconstitution. And all Florida Department of Health will offer safe-day test and treat. We have walk-ins, as you know, in the Hillsborough location. Same with VA. If a veteran is diagnosed, get them right into care. We now have Monday through Friday clinics actually at the VA with walk-in for STI care as well. We like appointments, but they can come in during theirs too. And then we have reducing community viral load is important, of course, but also, for the person's own immune system, it's important. So, very familiar with this. So HIV certainly affects the CD4 count, but what does it also do, right? The immune system, right? So going back to the good Dr. Canella's slides, you can see it actually establishes latency. So when you talk about someone living with HIV, they have latency in the CNS, in the lymph node system. You'll have, sometimes people have gastrointestinal symptoms as well. We saw some, I just saw a gentleman recently who had presented with GI symptoms. Joints, rashes, different things for different people, right? So really important to keep that differential that HIV unfortunately affects the whole system and can establish latency there. So eradication is very difficult right now. We're working on, flushing it from the system and eradicating it, kind of like we do in cancer studies. But right now we're suppressing it with antivirals. So HIV, even certainly without ART, right, will devastate not only your T cells, but also B cells, and also undermine CNS and cause inflammation. But even with therapy, we know our individuals have higher rates of all types of cancers, right? Cervical cancer, anal rectal cancer, certainly untreated HIV with lymphomas. So we know that for sure. And unfortunately, and many of you probably have already seen this in rotations, a lot of our presentations to care sometimes are with an oncological malignancy. And Atlanta, unfortunately, that was also very profound. They actually have dual specialties of oncology and HIV due to the acuity of those situations. So absolutely good to test. So what is U equals U? So your antiretroviral is started. You do want to check, even if you change antiretroviral therapy, you want to check to make sure that there's tolerance and that the viral load is suppressed. Why is that? Number one, integrase inhibitors are really known for causing aberrations in LFTs and sometimes lactic acidosis. They interfere with metformin sometimes with our folks who are on. Also, some people can have aberrations with liver functions. Sometimes they're symptomatic, sometimes they're not. So just good to check. You also want to make sure they don't have an archive mutation. If you're changing an ART, sometimes they can have a mutation that you might have not known about, they might not have known about. So that's important to make sure they're still suppressed. But also when ART is initially started, you obviously want to check them, same idea, but they should be suppressed around 4 to 8 weeks, especially if they're on an integrase inhibitor. If they're not, then there's something else going on. There might be another comorbidity interfering. They might not have perfect adherence. You might want to have that conversation. All right, so knowyourhivstatus.com. This is really, I think, a really nice website. Florida Health really did, I think, a good job here. But you can look for resources, and you can also refer your patients there. This also used to be able to request free kits, so ordering kits, and that's gone off and on. It may not be available. Last time I checked, it was kind of on reorder, so you have to kind of see if they have samples. But anyway, antiretroviral update. So one of the things, and I think that the end of last year I went through all the ARTs, and I was going to go through a little bit of that today, but you'll probably hear a lot about tenofovir, right? TAF, tenofovir alafenamide, versus TDF, which is tenofovir diproxyl fumarate. And that debate goes on kind of in the PrEP world and also the ART world. But certainly TAF is recommended for less bone and renal involvement. We know that for sure. However, TAF has also been associated with more metabolic aberrations, so diabetes, hyperlipidemia, and not indicated in PrEP with our cisgendered women. So you have to kind of balance that out. Because our integrase inhibitors are so effective, we actually can use 2 drug regimens. Before we used to do 3, 3 plus a booster. Those integrase inhibitors that I showed you on the previous slide are so effective in stopping the inhibition of the RNA that we can also just give dolutegravir rilpivirine or dolutegravir lamivudine, which is phenomenal, and now injectable, right? Dolutegravir, Cabenuva, so that's cabotegravir rilpivirine. So that's also very exciting. Any questions on that? Okay. And then our tenofovir is going generic. The TDF is going generic, and 3TC is all generic. Why is that important? Well, we get more PrEP people on PrEP, which is really exciting. We get more prevention, which is, I think, really, really the key. And also it's available to more people. Why did I put this fosfatesmir? Well, this is really exciting. There's new work in islatravir, fosatempiravir. Islatravir is an injectable that's going to last up to almost 6 months. Fosatempiravir is new, a CD4 cell attachment inhibitor, which is great. It binds the GP120, so hopefully it doesn't even have to enter the cell. And so we're working as time goes on for injectable medications and also medications that last longer. That can be used for pre-exposure prophylaxis or for treatment. So these are some of the older medicines you might see. At the time, Stribol was called the quad drug. It was the best thing since sliced bread. It was really good for treatment. It was fantastic. We were also excited when it came out because for adherence and for basically tolerability, it was really excellent. Thankfully, that has also evolved. And our go-to is kind of the TAF FTC bictegravir. We still use a lot of the TAF FTC ablotegravir cobicistat. That cobicistat, though, is really difficult pharmacokinetically. It interferes with a lot of other medications, so that's why we like to avoid cobicistat if possible. You'll see these on the boards though. So there's kind of the older version, Complir, which is TDF FTC mopivarine, and then the TAF version, same here. And then you're not going to see much of the efavirenz anymore in the TB world. It's well studied, but in the HIV world, we try to avoid it for CNS elevation. Anybody else know efavirenz effects? It elevates the CNS, so it will give people vivid dreams. It'll also make somebody who is maybe hypomanic more manic, so you have to really be careful about that. Okay. All right, then these are the long-acting injectable antiretrovirals. Why is this exciting? This is super exciting because it'll help adherence, it'll help transmission, it'll help prevention, and then hopefully we can get a vaccine and really end HIV. But this is really exciting. And Florida, probably you working in the health department, the ADAP program, they do a great job. They give drugs to folks who need it. And what this is they're piloting this as well. It's now available in the VA. So that both the cabotegravir rilpivirine called Cabenuva, and also we're working, rolling out shortly, it's been approved in VA of injectable cabotegravir for PrEP, and that's every 2 months, which is really exciting. All right, HIV vaccines. So we've been working on it. I wish I were more directly working on it all. No, I'm just kind of following the literature, but there's really exciting things happening. Broadly neutralizing antibodies called bNAbs, you might have heard, which is basically preventing the virus from attaching and being effective. There was a really exciting RB144 vaccine trial actually done by the Department of Defense, and there was one done in Thailand as well. It's been kind of going along, but it's a very tricky virus. But there's also an HIV vaccine trial network, so we're all of us are trying to see how we can help in that. That's very exciting, and there's a public-private partnership as well. So there's a lot of good work going on. Obviously, with COVID, the attention has been to COVID, but we're trying to work on using those technologies to extrapolate for HIV vaccine work. Okay, how to identify and refer new HIV cases. So acute HIV syndrome, right? Rash, pruritus, fever. I would say maybe half to maybe less of folks will actually tell you that story, maybe even less. Same with syphilis. Sometimes people come to you and they say, I've never had a rash, never had a lesion, and it's true. So they may have seen it or may have not happened. We always talk about risk behavior reduction, and this is kind of the soft skills here, but it's important. In unusual or persistent skin lesions, I have seen a lot of Kaposi's, especially in the health department space, new diagnoses, and also we now refer more for oncology care. It used to be, and also for your boards, it's really starting ART, but we do give doxorubicin, but I won't say commit to chemotherapy, but we do give chemotherapy for Kaposi's. So those are basically those. This is the HIV hotline, helpful for patients as well. Obviously, when you're in the health department or the VA, you have go-to folks for the health department's disease and interventional service, and also your attending will be able to link you with those folks. And also in the VA space, myself and Carrie Wilsinski, the AID APRN, but also we have other support networks as well. Okay. So barriers. So I'm going to kind of speed through this because I know they're a little bit more soft skills and I want to kind of go more to the science of it. But barriers to, what are we doing on time? Okay. Barriers to HIV testing and care. So just know that there are a lot of barriers. So that's why, at least in the clinic, if someone comes late, I always try to get them in It's very hard for people to get care, and trying to organize that. And people ask me, for things, I try to help them as much as, give them the resources and refer them obviously as possible. And there's a nice network that you can work with. We have seen stigmatization and ostracism by family, friends, and partners. There was a case in the health department where a woman's child was basically, the family decided that they didn't want her to take care of the child. I mean, it's really sad things. So without, violating HIPAA, there's a general stigma of people being ostracized by family and friends. So it's very, very real. So we're very careful about making sure we can write a letter if they really want letter with results, or do we really leave a message, making sure that you've confirmed that that person wants you to leave a message, and or that person's phone is really important as well. So let's see here. That's good. I think that's good. Yes, just in terms about stigma, not to get too into politics, but just to know that, because it is relevant at the Florida Department of Health, there's HIV felony laws in many of the southern states. And so you'll get questions from your patients about, how do I reveal my status to my partner, and what does that mean? And so basically, I mean, it's always good to be open, right? I really don't talk about, felony laws, or, you're going to break the law if no, it's really about trust issues and relationship issues. But unfortunately, there are still laws on the book. Technically, is it enforced? No, not that much at all. But it's important to maybe to be able to answer that question, or to refer them to someone who has more information. It might come up. So that's it. Stigma, basically. One of the things I ask about adherence is if their family knows their status. Chances are, if their family does not know their status, or if they're traveling, if they're housing insecure, it might be difficult for them to continue with their adherence, right? If they're trying to hide their medicine, or if they're trying to go from shelter to shelter. So that's important, I think, to ask. Some patients may not tell you that right away. And so that's important when you're doing your social history in clinic. If they're new to clinic, or if they're following up, or if they've been lost to care, there's probably a good reason why they're not coming. As I always say, sometimes your most important note is your no-show note, because that person probably needs your care. So just, as you can imagine, just try to see what's going on with them in the HIV world. Undetectable is untransmittable. So this is really exciting. How many people have heard of undetectable untransmittable? Okay. Anybody want to tell me what their interpretation is? Volunteers.
Have a viral one, they can't transmit.
There you go. Exactly. So U equals U, eliminate stigma. Exactly. And this is really groundbreaking. Actually, this is really exciting, because before, people really did have a lot of stigma. Back when we counseled people wanting to conceive children, we would have to, really counsel them and, figure out how to not have not transmit HIV, and weren't sure how that would work. And thankfully, these trials have really shown that people can really live, normal lives in terms of reproduction and relationships. So that's really wonderful. As long as they're undetectable for about 6 months, then they're untransmittable, which is really, I think, game changing for a lot of our patients, and certainly for the scope of the public health impact. So that's very exciting. So this just shows you the 6 months, and there's effectively no risk, which is really exciting. And this is what I tell my patients when they're newly diagnosed, or even if they're asking about HIV. I really try to keep it optimistic, because a lot of your patients have probably heard a lot of negative messaging, and not and probably have a lot of fear and problems with their diagnosis. So it's nice to kind of maintain optimism, and to give them a appropriately optimistic message, I think. So this is a paradigm shift. And what else? Yes. So we don't we used to have to concern sperm washing or in vitro, and it used to be a big deal, but now, thankfully, we don't need to worry. A woman living, or cisgendered women, or I should say biological women living with HIV will still have to undergo the right screening. Obviously, that's a kind of a whole other lecture, but certainly in terms of the conceiving part, should be in good stead. All right, updates on PrEP and nPEP. So I guess take a stretch. Stretch, deep breath. So I wanted to mention PrEP and nPEP because it comes up in the dialogue, and I think it's I think we focus sometimes so much on HIV that sometimes I'd like to focus also on preventing HIV as well, because I think we get pretty good at giving antiretrovirals and managing them by our first year of fellowship, and I want to make sure that we keep you active and looking for HIV prevention opportunities. So this is a taco bus. This is done by the Florida Department of Health. They did a really nice campaign. I think they did a really nice media campaign around PrEP. And they had it in Haitian Creole, they had it in Spanish, and they also had it in, of course, English, which is great. And why is this important? Well, it's reaching all of our groups that we talked about, and so that's why that's important. And so this is also some of the bus wraps that they've done, which I thought was kind of cool and hip. And then also, I think their messaging is I think it's good. I mean, I think they vetted it with the community, and I think it was really right on target in terms of getting the message across. So how effective is PrEP? Well, it improves with adherence. So if someone is taking their PrEP medicine, their TDF-FTC, their TF-FTC, or getting their cabotegravir injection, they're going to be almost, 99 effective. Here, I can let this person. Oops, did I let them in? Toohey? Okay, I just kind of moved it around. Okay, good. So we have adherence. Why is that important? Well, there's the, do you remember the new CDC guidelines for PrEP when you monitor? There's this new guideline where you check the HIV viral load in addition to the HIV antibody antigen. And why that came about is what we think, and speaking to the CDC, actually, we were very fortunate we got to speak with them. They were worried about breakthrough virus. And what we noticed is that in spaces where there's excellent clinical navigation, excellent adherence, the breakthrough is very, very, very low on the oral regimen. So that's why in your practice, if you're worried about adherence, certainly go ahead and check that HIV viral load for breakthrough. But generally speaking, we've had really good adherence profiles on the oral regimen. And the VA is just one example. They have very good outreach, I think, but also remember the medicines are all within the VA, so it's a little bit easier to track. They've noticed that they have very, very good adherence and very, very few breakthroughs, and then usually that's adherence related. It's not drug failure. So that said, the more adherent, the more effective, and that's what I tell my patients too. And I have them take it every day. You've probably heard of the 2-1-1 PrEP, which is helpful, but it's not the best in terms of guaranteeing HIV prevention. PrEP 101. So essentially, you can do your TDF daily or your TAF daily. We've already talked about renal bones. You have to have good kidney function with TDF. Descovy is very, very good as well. You want to worry about weight gain. Not yet for cisgender females, still not so. And then injectable. So you definitely want to take HIV at initiation and at 2 months for your injectable cabotegravir. And it is a good practice if you are worried about acute HIV infection when you initiate PrEP. We didn't used to do that a lot, but if you're really concerned, it makes sense to get a good baseline. Otherwise, right, you're going to give them resistance if you just give them a 2-drug regimen such as this. Okay, I'm not going to go too much about this, but Florida Department of Health has a very, very nice PrEP plan of action toolkit. And the CDC also does, and a lot of these have been updated, but I just wanted to show you that if you have questions, these are very, very great, wonderful go-to resources. This is also just segueing now the PEP, so post-exposure prophylaxis. So there's now an order menu at the VA, so if you get a call, obviously run it through your attending, but there's an order set through the emergency room and also through infectious disease order set. To actually give out the medication all at once in the ED setting and to start within that 72 hours. That's literally been a lifesaver. We've had really good success with that so far, and it eliminates a lot of that anxiety because a lot of this is your health resources, right? It's how you mobilize your meds and your staff and getting the medication to the patient and convincing the patient it's important. So if you'll notice in your practice, if you automate the parts that can be automated, right? So if you can automate the labs, if you can automate the medicine being available, if you can automate the follow-up labs, then you can concentrate on the patient part, right? And you can concentrate on the follow-up part. So that's pretty good guidelines, I think, for pretty much anything infectious disease with this, including tuberculosis. Once you get those mechanics down, then you can focus on the other kind of trickier, softer skills, but important nonetheless. Npep, so it's technically a 28-day course of, oh, sorry. Yes, sorry.
About the PrEP, the last slide.
Yes.
You said that it's not approved for cisgender?
So the TAF. So sorry, I might have garbled that with my mask. Yes, so basically you have the TDF-FTC, the tenofovir, right, Truvada, and then the TAF-FTC, the Descovy. The TAF for cisgendered females, my understanding is it still has not been approved for cisgendered females. The reason, it's the blood level of that through the vaginal mucosa specifically. TDF, remember, so TAF is intracellular, right? So that's how it prevents HIV, but also more so, that's why it's gentler and kinder on your kidneys and bones, because it's intracellular, right? TDF is more extracellular, right? So the reason why it's a little bit harder on your bones and kidneys, but it's recommended for people who are using drugs because you have to stop it at the mucosal source. And it's also better for your cisgender women. Yes.
So we can still use the TDF.
Oh, definitely.
Okay.
Oh, yes. I'm so sorry. Sorry. Yes. Team. Yes, absolutely. You definitely want to use TDF FTC for your cisgender women, and also your pregnant or wanting to conceive cisgendered women. Absolutely critical. No, thank you for that clarification point. For sure. And to that point, I believe cabotegravir is now for any person, but I would be cautioned with intravenous drug use and still caution with cisgendered females. Just we don't have that data yet, but yes, that's right. Okay, good. Any other questions? That was a very good question. Any other question? And that was actually, yeah, go ahead.
It's about the injectable form.
Yes.
So who is a candidate for it?
Yeah, it's a good question. For injectable cabotegravir, yes. So it's really someone who is, so in terms of the science of it, obviously you want to make sure they don't have any HIV infections. You want to take a HIV viral load. The good news is, well, you also want to screen them, obviously, for hepatitis B, right? You don't want to, treat them and have them partially covered with antiviral with Hep B. But technically speaking, really anyone would be a candidate. I think if there's a renal, I have to check it, but I think there's a renal component to it. But it is very good. My understanding, it's all comers right now. And I'd have to look at the latest, but I think it's really anyone would be available. Now they do have to make sure they come in for the drug. I know it sounds obvious and clear to everybody, but you'd be surprised. There is some tail of pharmacokinetics with that, and so people would be at risk for infection if they didn't, obviously. But I think you have to have an adherent person. You have to make sure they come in for labs. And I believe at this point, it's all comers in terms of genders that I can see. So it's very, very exciting. I will say cabotegravir, though, has a little bit higher risk of breakthrough infection just because it is a single agent, right? And if they are exposed technically to someone with a cabotegravir mutation, right, there's a theoretical problem that they could have a breakthrough. But that's really in theory right now. It's an excellent question, and I'll double check to see if there's any updates on that. But my understanding, it's all comers at this point. And I don't know if there's any specific guidelines in pregnancy though. So I think your go-to would still be TDF FTC. But I will definitely look it up and get back to y'all. I've been so focused on trying to get it approved that I need to update myself in terms of exactly who can get it. We treat a lot of obviously cisgendered men and in our VA space, but yes, I think for our pregnant ladies, definitely TDF is the way to go, and FTC. Anybody else? Okay, good, excellent questions. Oh yes, okay. So this is important. So when you're seeing somebody from Endpap, whether it be, I'm trying to think when you would, probably the health department perhaps, or maybe somebody you run into for clinic. Sometimes they follow up in the VA clinic. It's technically 28 days of it is actually a TDF FTC. Why is that? Because you want the extracellular protection, right? So we don't do nPEP with TAF, right? We do nPEP with TDF. Raltegravir, why? It's a little bit more studied. Can you give them dolutegravir? Sure. Can you give them Biktarvy? Not really, because it has the TAF, right? So you don't want to get too fancy. So it's really your TDF FTC and your raltegravir. You can also give them dolutegravir, which has worked well. You definitely want to get your baseline, as you can imagine. I know most of you know this, but antibody, viral load, and you do want to check your hepatitis A, B, and C panel for sure. Remember, your TDF will protect you against hepatitis B, but it's nice to get that core baseline. In the VA, we actually give 30 pills just because of the way that it works out, but you get the point there. And then you just follow the same regimen and protocol for occupational exposure if you're following a patient for that as well, which we do. And yes, and then you just follow up your HIV antibody antigen. And it's really working with the patient too. So if they want to be followed up at a month or 2 months, that's absolutely fine with me. If they really are worried about Hep C transmission, I check them earlier, and there are specific guidelines to that. But guidelines are guidelines. You have to just make sure that you're in communication with your patient or your team is. All right. So we'll do this and then we'll take a stretch break. How about this? These are some extra resources for you. Oh, so exciting. Let me just put a blurb here. So we are super excited at the VA to offer this national HIV curriculum. Okay, so I know y'all are taking your boards, so we will let you be in peace until I take your boards. But I would love for you to look at this. Why? Well, number one, you get a certificate, looks good on your resume, but also it's really good because for the real reason, we want you to really understand the basics of HIV, because lectures like these are, okay, but I really want you to get kind of a nice foundation in a sequential manner. And I think this actually has been vetted by the CDC, very, very excellent educators, and it'll give you the step-by-step so that your brain can, process in terms of, the step approach, which I've done here in abbreviated form, but I think it's important that you look through this perspective. And if that's okay, I added, all of you probably should have gotten an email from me. Basically, you and Dr. Katzman is on that as well. She can see your progress as well. And no pressure. This is over 2 years, so we just want you to kind of learn and work through it at your own pace. We're going to have Dr. Morano work with y'all a little more closely in a collaborative way and go over some of the high points. So to help you understand some material. A lot of it is straightforward, but a lot of it's really kind of cool to talk about and to understand, because it has implications for other viruses, right? It has implications for COVID and monkeypox virus. So anyway, any questions on that? But we're so excited to be able to offer that this year. There's also a Hep C national curriculum. There's an STI national curriculum. They're really great resources, even if you just click through them. And on those sites, they have the medicine. Actually, they have the screening tools. It's really a one-stop shop for HIV. It's really fantastic. These are educational training sessions that they have. And this is really nice. So I've called this a couple of times with kind of difficult, kind of unusual cases. You can always obviously run them through your attending, but if you're in practice and you're kind of you don't have that support as readily, you can certainly call this as well. And it's like a kind of a warm line that they have that you can ask really great questions. And this is it from, oh, yes, there's a PrEP locator. So we get this question a lot from our patients. I'm going to Missouri, how do I follow up my PrEP there? You can look that up. I've done that in both the health department and VA spaces. The VA is a little bit easier because you know the VAs, but the health department space, you can look at other health departments, other Ryan White clinics. It's really great. And this is nice. This is also very nice. So this is all great things. And so there are many ways to prevent HIV. So prevention, testing, treatment, barrier protection, etc. And fast track cities. So Tampa is continuing to work on the fast track cities as part of the formal CDC and the HIV epidemic. So your health departments are doing great work in terms of getting a good consensus together. And Dr. Jackie Sherbuck is heading this up with Dr. Sempunwit. And I think Dr. Ranke is probably involved as well to get Tampa kind of more visible in terms of working on HIV control and making that link from hospitals to health departments.